Very simple. It's better outcomes, better safety, and better service. That's in the numerator. It's a ratio. Value is quality in relationship to how much you pay. That's what value is. In healthcare, quality, which is the numerator, top part of that equation, is the outcomes you get, safety, and the service. And those are all measurable. Every one of those are measurable elements, especially when you look at outcomes if you just start with some of the key conditions like diabetes, like hip surgery, treating people with asthma. If you begin with a few key conditions, you can define what outcomes you would like to see. And then safety records, I believe you already are collecting that in this country. I don't think it's widely distributed or known, but it is being collected and it's available. And patient satisfaction, it's not clear that that's being collected in this country, but in the United States, for instance, we do collect patient satisfaction information on hospitalized patients. And we have a very good sense of that for all of our hospitals. But individual organizations collect patient satisfaction all the time for themselves. So we're quite used to doing that. And then in the denominator is the spending, the amount of dollars that are spent for the care of patients. So that's the ratio. It's outcome, safety, and service compared to how much you spend. That's value in healthcare. Therefore, if you can reduce the spending and keep the outcomes the same and the quality the same, you're getting higher value care. On the other hand, if you improve the outcomes, people are back working, they're not in the hospital, lengths of stays are shorter, all of that sort of thing, and you're getting better service, and the prices stay the same, that's high value care. That's higher value care. And then the ratio can change. Sometimes you'll have to spend a little more money to get better outcomes. It just so happens that in the United States, without any conscious plan to make this happen, but it just so happens that in the United States, when you sit back and you look at the results, the outcomes, and the spending rates throughout the country, just so happens that there are lots of places that get very high value care, really good outcomes, really good safety, really good service at much lower spending rates than is average in the country. And when you look at those places that are doing it, there are a number of characteristics that are quite similar, but it turns out that integrated and coordinated care seems to make high value care happen. And I can tell you over 30 years, those of us that have been involved in integrated and coordinated care have never sat down to say, let's do it to get lower costs, to get lower spending. We never even thought about it. We just focused on the quality equation and what was best to do for patients. It turns out as a byproduct of that type of practice style, the way the physicians work together with the nurses in hospitals, the result of integrated coordinated care is lower spending over time. So there's a big message there. I mean, we have a natural experiment in the United States that people should learn from. And I gather in my visits to those three places that people were thinking along those exact same lines. If we look carefully at the experience in the United States, and frankly, if you look at the experience in other foreign countries that I visit, and I've been to many of them, there are some common characteristics that we can perhaps learn from, at least try to learn from them. One I've already mentioned, and that is the fact that integrated and coordinated care seems to make a difference in controlling the way the patients are managed, reducing utilization. And what I mean by reducing utilization, I mean doing the appropriate thing at the right time in the right way. That doesn't mean doing less. That means doing the right thing at the right time. And if we do the wrong thing in a bad way, utilization goes up because patients will get complications, they're in the hospital, and they probably didn't need the procedure to begin with. So focusing on appropriateness in the way we provide care and how we provide that care is a delivery system question. The delivery systems that have gotten the better outcomes at lower cost have been those that provide integrated and coordinated care. I have to keep emphasizing that. However, there is no one standard way to give integrated and coordinated care. It all depends on the region you're in, the location, the city, the town, the country. It all depends on what individual patient might need. Some patients may need rather intensive home visits if they have, for instance, dementia or something like this. They may need very carefully thought through end-of-life care, for instance. That is quite different than what you would get if you go into an acute hospital that's used to doing everything to everybody when they come in the door. It might require very skilled specialists making a single decision on what is the next best thing to do for this patient. That could be the most expensive thing. But if it's the right thing to do, you will save money in the long run by doing the right thing, even if it happens to be the most expensive. And you forget about doing all the less expensive stuff. You just do the most high-value thing right off the bat. There's nothing of less value than providing somebody a worthless treatment or a worthless medication, even if it is a cheap treatment and a cheap medication. It's of no value. It's a waste of money. So when you look carefully throughout the United States now, that kind of care has been provided in many different settings. My answer to that is you as a country make a commitment collectively to what you really want out of healthcare. And if you truly want high-value care, better outcomes, better safety, better service, lower costs, you say that. And as I mentioned before, you begin to measure it and look for it. And then you stand out of the way and let the physicians and the nurses and the hospitals do whatever they need to do. Let them run experiments. Let them permit them to form into groups if they want to, or smaller groups or larger groups, and let experiments flourish. As they come forward with ideas, I can easily see I visited 3 different places. I can see 3 different models all being allowed to come forward, and I would bet every one of them would result in better outcomes, better safety, service, and lower costs, and they would all be doing it slightly differently. They would have some core key ingredients: electronic connectivity, interaction with each other, a spirit of cooperation. They're going to need to have that. If indeed there's a commitment to that, then the next step to get physicians particularly to participate in that, the next step it requires, you start with that clear vision, and the next step is leadership. Who are the key leaders? And you back those key leaders. And then let the leaders begin to work with all of the staff. And you do not need all of the physicians to agree to this. You only need roughly the square root of n. That's the term we use. So if you're in a community and you have maybe 200 general practitioners, I really don't know, you just take the square root of that. You may need, let's say, 20 doctors to take the lead. And then and frankly, among those 20, you should actually bring in some of the naysayers. You get a few of them in there, some opinion makers, respected physicians that have different opinions. But they have to be respected. You can't bring in the losers. And in England, I get a kick out of this. There's so much talk about equity, and there's a huge difference among physicians, and we all know it. All of us who are physicians know there are certain doctors we don't want to see. And we just have to accept that. Not everybody is as good as everybody else in everything. There are some people that have strengths and weaknesses. So you look for some key leaders and you begin the process of educating, teaching them skills that they will need to make teams function, to look at how we re-engineer the practice, how to make better use of IT. You train them. And then as you're training them, you're giving them the skills, you're giving them technology, you begin to build a broader base of physicians that want to begin to participate. And you will eventually hit a critical mass that you're ready to move along with. But the key in all of this is that eventually the leadership can lead, the vision can drive it, the leadership can lead, but eventually everyone else needs to feel it was their idea. Everyone else that's going to really lead this. And that takes a while. You have to keep talking to them and reminding them. And I can tell you one of the people I get a lot of inspiration from is Winston Churchill. That's the way he did it in World War II. He talked to the people all the time. The people knew what was happening, and it was their war. When the people were being bombed here in England, everybody pulled together. Everyone felt that they were doing a component of it. And that's the kind of thing we're talking about here. This is basically a major change in direction. And it does require that you need almost everybody to be buying in as you move forward. But you don't need everybody to start with. You got to get the bus full and out the station. And you don't need everybody on the bus. You just need a smaller number. But then the leadership has to give that smaller number the support that they need to make this happen. And eventually then you'll find that the doctors won't be buying in. What they'll be saying is, well, my idea, you know, you're holding me back. There are things we want to be able to do. We need help. We need resources. Skills in leadership. They're going to need some skills on how to do it, some skills in information technology, managing of teams, lean management tools, engineering, system engineering, process engineering for their own practices, but also to take care of people at home and in the hospital. And that takes some formal training. In many organizations like Mayo Clinic, we have a formal, what we call a quality academy, and we train everybody in those tools. And for most physicians, they're going to say this is really kind of dumb. You know, you do diagrams and figure out all the steps and processes, but they need to have been trained in it to understand that that's what it takes. They don't even have to do it. You get engineers to do this, or administrative people to do it, or some leaders will do it. Some physicians naturally understand this, but most do not. They've not been trained, they haven't been exposed to it. So you need some training there. Tools, technology, they have to be able to be supported with the technology. If you can create that environment, you can actually make this work. I read the white paper, and it's way too long, too many words, too confusing. I don't get a clear vision. I know there's a clear vision somewhere, but I don't really get it. As I read through it, it sounds like the white paper is not pushing so much on the vision and what we're trying to aim for and what we're going to measure. It's a little more too much about how we're going to do it. They've got all these organizations and all this sort of stuff. I really think, and I've said the same to our congresspeople in Washington, they should demand high-value care and say we're going to measure it and look for it. That's it. That's what they should be doing. Whoever's producing high-value care is better. Then you try to align your payment mechanism to make sure that those places that are getting higher value care stay in business. And to stay in business, it's not a break-even. There's no such thing as nonprofit anywhere in the world that can stay in business. You have to make sure those places that are getting you better outcomes, better safety, better service, and lower spending over time make a 2 to 3% margin. They need capital to be able to replenish themselves. I'm not saying they're going to split it up. I'm not saying to do that. But they need it to stay in business because, and this is true for the U.S. too, we're going to need those good organizations over time. So that's basically what your parliament and your leaders ought to be looking for. They ought to demand those results. Then let experiments run and see who actually can attain them, because you'll be surprised. And if you put too many prerequisites in place, too many regulations, you can actually completely stifle some innovative new things that can actually, can occur. The politicians are going to have to realize that change requires change. And it's going to be hard for everybody. You can't just blame the specialists or the hospitals or the GPs. Everybody is going to have to put some work into this. And the people who run the hospitals, I would assume that's part of the NHS, but the people who actually run those hospitals are going to have to manage them. They're going to have to actually come to grips with the staffing levels, how long are the ICU stays, what's the process flow in the operating rooms, what's going on in the ERs. They're going to have to participate. And especially if the GPs accomplish what I hear everybody says you want them to accomplish, and that is have fewer people going into the hospital, have fewer people being sick, have fewer people using the emergency rooms. If that happens, what are you going to do with the hospitals? There's just going to be less demand. So you got to face that up front. And the politicians have to be brave enough to talk to the public about that. I know that's difficult in the US. It's probably almost impossible here. The only solution I can figure out for that is you got to get all of these decisions out of politics. You got to move them somewhere else. And when you move it to the somewhere else, and in the white paper it alluded to that, but it also, if I read it carefully, the white paper I think said something like, but you can't close hospitals. you can't tie people's hands when you're trying to give them that authority and responsibility and accountability. You have to let them do it. Meanwhile, the leaders in the political area measure the outcomes. They're looking at the outcomes, safety and service, and they're spending over time. And that's why it is so important to start with a clear vision of what you really want. Because if you don't have a clear vision of what you want, then anywhere you get might be okay. And it may not be where you want to be.